Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today we will be beginning part 1 of our overview lecture on prostate cancer. Prostate cancer is an extremely common malignancy in males, affecting around 1 in 8 men in their lifetime. And it is actually the second most common cause of cancer death in males, secondary to lung cancer. Now, as you can see from the stage distribution and 5-year relative survival images, most of the time prostate cancer presents as localized disease. And when it presents with either localized disease or just regional spread, the 5-year survival is actually very, very high, close to 100%. However, when prostate cancer has distant metastases, and it can progress to having distant metastases, the survival rate drops off a lot. So in medical school, you often hear, more men will die with prostate cancer than from prostate cancer. And while that is certainly true, when prostate cancer is aggressive, or when it does present with metastases, it can be life-threatening, and so it's definitely nothing to be taken lightly. Because prostate cancer is just such a common disease, kind of similar to the literature in breast cancer, the literature in prostate cancer is also very, very vast. If you think of a question, there's probably been a study done to address it. And even how we kind of stage and risk stratify prostate cancer, to me at least, feels very complicated when you compare it to some other cancers. And so that's why we're dividing this overview lecture into 2 parts, just like we did for breast cancer. And in this first part, I'm hoping to kind of cover the presentation and workup, as well as the staging and risk stratification of prostate cancer, which I think can get a little bit complicated. And then we'll stop there for part 1 and then come back in part 2 to talk a little bit about treatment options and kind of summarize how we manage prostate cancer in various scenarios. Let's get started then by talking about presentation and workup of prostate cancer. The vast majority of the time, prostate cancer is going to be detected on PSA screening. And it's typically asymptomatic, or if patients do have urinary symptoms, they are often related to benign prostatic hypertrophy. And so if patients have symptoms, they might be things like lower urinary tract symptoms, we call them. So things like frequency, urgency, nocturia, hesitancy. If it's more advanced, they might present with hematuria or hematospermia. But again, oftentimes are going to be detected just on PSA screening. So there's been a few different randomized trials and meta-analyses to kind of look at the value of PSA screening. And it seems that PSA screening doesn't actually give any apparent decrease in the overall mortality of patients. However, screening does seem to reduce the incidence of distant stage prostate cancer. And so it's definitely something that should be considered for patients. And it's often something that happens prior to patients ever entering the radiation oncology department. It's often handled by their PCP or their urologist. The AUA has a nice guideline for prostate cancer screening. And for patients less than 40 years old, they're typically against routine screening. For patients age 40 to 54, they recommend screening patients that are of higher risk. So if they have a significant family history, patients of Black race tend to have higher risk of prostate cancer as well. And then for ages 55 to 69, it's really a shared decision-making process. And as you'll see is a common theme in how we manage prostate cancer, when patients have a life expectancy of less than 10 to 15 years, oftentimes things that we do for prostate cancer aren't really going to be life-limiting or affect their overall life expectancy. And so when men have a life expectancy of less than 10 to 15 years, especially when they're over the age of 70, the recommendation really is to not screen. And you'll see that even when we know that patients have a diagnosis of prostate cancer, if their life expectancy is less than 5 to 10 years, then we're inclined to treat it less aggressively than we would for an otherwise healthy individual. The reason that these guidelines are the way they are is that there's really a concern for overdiagnosing and overtreating prostate cancer. When we subject a lot of patients to unnecessary prostate biopsies, they're also at risk for complications such as infection from those biopsies. And then, there's also various risks versus benefits of different prostate cancer treatments that we might offer, as you can imagine. And, on the whole, this entire process does cause a lot of anxiety to patients. And so it's really something that should be handled with care. Again, a lot of the times the PSA screening and the next steps are determined by the PCP or the urologist prior to the patient ever even entering the radiation oncology clinic. But as radiation oncologists, I think it is something for us to be aware of. And so, I think the big takeaway here is that most often prostate cancer is going to be detected on PSA screening. And typically a PSA level that's higher than 2.5 to 4 nanograms per deciliter is a PSA level that's considered, at a higher risk of cancer. And that's something that should be followed closely. And if it's, if we're really concerned about it rising, then we can consider a biopsy at that time. Now, one thing that I learned sort of recently is that there are some men who, might be already under treatment for benign prostatic hypertrophy. And typically, the drug that we think of to help manage the symptoms of BPH is tamsulosin, or the brand name is Flomax for tamsulosin. And the mechanism of tamsulosin is really to help relax the smooth muscle in the prostate, affecting the urethra, and kind of relax that smooth muscle and help with urinary flow and help with some of the obstructive symptoms that can happen from BPH. Some men, however, will also be on finasteride, which is a 5-alpha reductase inhibitor that kind of, works by the idea of decreasing the testosterone going to the prostate, which, obviously drives BPH. And so a lot of men might be on finasteride, either for BPH, it could also be for hair loss, androgenic alopecia, or something like that. And when men are on finasteride, it's well documented that can reduce your PSA just from being on finasteride. And so we still monitor PSA in men that are on finasteride, but what the kind of rule of thumb is to double the PSA value. So if you know that a patient is taking finasteride and their PSA is 3, then in a person that's not on finasteride, the actual PSA value probably corresponds to more like 6. So the rule of thumb is to kind of double that. I had a patient recently who came in with a PSA value that was probably something like 2 or 3, and they were on finasteride, and I was wondering, why the urologist was concerned, why they went ahead and got an MRI and a biopsy, and it turned out that, when you're on finasteride, you have to kind of double the PSA that you think about. So I just wanted to note that because it's something I learned kind of recently. I think it helps to consider the prostate anatomy because it helps us understand the difference between BPH and then also prostate cancer. So the prostate is composed of 2/3 glandular elements and 1/3 fibromuscular stroma. The fibromuscular stroma is really the anterior zone, and then the glandular elements are in the central, transitional, and peripheral zone. So the transitional zone, which in this diagram here is really that blue color, is sort of the site of BPH. So BPH tends to occur more in the transitional zone, and it tends to be more in the center. The peripheral zone then, which is shown in red in the diagram here, is typically where the majority of cancer arises. And so when men present with what we call obstructive symptoms, so symptoms like having trouble starting or stopping their urinary stream, that would be kind of an obstructive symptom. That's really when we worry more about BPH versus cancer, because we know that the transitional zone is what is surrounding the urethra, and that is more likely to lead to those obstructive symptoms. The peripheral zone often is not symptomatic really because it's not directly affecting the urinary flow. And that's sort of the site of where majority of cancer arises, in that peripheral zone. And then there is another image I want to point out on the right-hand side of this slide. And it kind of just shows how the prostate is divided into the right and the left sides. And then there's a base, a midgland, and an apex. And again, this is one of those things that didn't logically make sense to me. But the apex of the prostate is kind of the narrowest portion that is most inferior in the pelvis, and the base is the part that's sort of the widest and is closest to the seminal vesicles. And I think these terms are just important because when you're looking at imaging, when you're trying to describe physical exam findings and things like that, it helps to kind of be able to use these terms: base versus apex, transitional zone, peripheral zone, and so on. So the function of the prostate is to contribute to the production of seminal fluid in biological males. And around 30% of the seminal fluid comes from the prostate itself, but the majority, 70%, comes from the seminal vesicles, the testes, and the bulbourethral glands. The prostate is heavily regulated by the male hormones, and testosterone really acts as fertilizer for both BPH as well as for prostate cancer. So just to kind of briefly review the hypothalamic pituitary axis, LH, which is secreted by the pituitary, acts on the testes and leads to the production of testosterone. And then ACTH, also from the pituitary, acts on the adrenals, causing the release of DHEA, which is converted to testosterone. And the conversion to dihydrotestosterone is catalyzed by 5-alpha reductase. And then ultimately, the androgens that are produced act on androgen receptors, contributing to prostate survival, growth, as well as PSA secretion. And so, as we talked about, when patients are on finasteride for things like BPH or androgenic alopecia, 5-alpha reductase is inhibited, and so that PSA value is reduced. And so we need to keep that in mind and kind of account for that when we're evaluating their PSA. Okay, so we talked about the presentation of prostate cancer. We said that most often it just presents with an elevated PSA that's detected on screening. We talked about normal prostate anatomy and physiology. And now I'd kind of like to get into the workup and staging of prostate cancer. So in reality, when patients present to the radiation oncology clinic, they've typically seen a urologist, they have an established elevated PSA, and the urologist probably has pursued some next steps and gotten things like an MRI, they might have gotten a biopsy, and by the time we see them, a lot of workup has already been obtained. But for the purposes of our board exams and just as being good doctors in general, it's important for us to understand the steps for staging and workup so that sometimes when patients do present to us with incomplete staging, we kind of get a sense of everything that needs to be done. So always our first step in working up patients should be getting a history and physical. In the history, we always want to focus on obtaining their urinary, sexual, and bowel symptoms at baseline. And we can use tools like the IPSS urinary score and the SHIM score for sexual function to kind of help establish kind of a baseline urinary and sexual function for these patients. But you always want to ask them about what type of urinary symptoms they're having, how often are they getting up at night to urinate, are they having any obstructive symptoms like trouble starting or stopping a urinary stream, what's their sense of frequency or urgency when it comes to urination? Are they sexually active? And if so, like how would they kind of rate that sexual function? And then also bowel symptoms. Are they having any, loose stools or constipation? Are they having any rectal bleeding? Do they have any baseline conditions such as inflammatory bowel diseases like Crohn's or ulcerative colitis? These are all very important things for us to establish. In terms of exam, you always want to get a digital rectal exam as well. And when we get to the staging, we'll talk about this. But historically, the T staging for prostate cancer was always done based on digital rectal exam. And if you look at the AJCC version 8 guidelines, T staging should be done based on the digital rectal exam. So you always want to get a digital rectal exam. In terms of labs, we'll get a PSA, and oftentimes when a PSA is elevated, it doesn't hurt to recheck it and confirm that it is in fact elevated. It also helps us to get a serum testosterone because if we do initiate any systemic therapy like androgen deprivation therapy, it helps us to follow that testosterone and make sure that it's truly suppressed. In terms of imaging, I just mentioned, in the olden days and historically, digital rectal exam was kind of the way that we locally staged prostate cancers. In the modern era, though, a prostate MRI has been really helpful to visualize intraprostatic disease. And, the NCCN actually strongly recommends obtaining an MRI prior to a biopsy, because when we get an MRI and we see a lesion, we can actually target it with our biopsy. Whereas historically, we would just randomly sample 10 to 12 different cores in the prostate. When we can see the disease on MRI, it's much more useful so that we can specifically target that area and biopsy the imaging abnormality that we see. And then the other thing that MRI has influenced in the modern era is our staging of prostate cancer. You can imagine the digital rectal exam is far less sensitive at picking up things like extracapsular extension or seminal vesicle involvement. And so our prostate MRI sometimes can upstage the disease. Now, whether that should affect our treatment paradigms for patients, I think you might find is controversial depending on who you talk to. But I think the prostate MRI definitely gives us a lot of information. And I think most physicians would agree that, when things are obvious on the MRI, like when there's obvious seminal vesicle involvement, we need to treat patients as kind of a higher risk based on that factor. So that was a bit of a long tangent, but prostate MRI should be obtained to visualize the intraprostatic disease to help guide our biopsy. And we'll talk about MRI in more detail shortly, but we're typically obtaining a multiparametric MRI. So at least a T2 sequence and at least one other sequence, such as dynamic contrast enhanced or a DWI, just to help us to visualize what's going on. When patients have higher risk disease, so if they have unfavorable intermediate or high risk disease or something more aggressive, we need to obtain further imaging to rule out metastatic disease. So historically, we would always just obtain a technetium 99 bone scan to rule out bone metastases, since that's the most common site of distant metastasis. However, we now have more sophisticated imaging and we can often obtain PSMA PET CT scans. And there was a pro-PSMA study that showed that PSMA PET CT scan actually had 27% better accuracy for detecting nodal or distant metastases versus CT scan. Now, PSMA PET scans are not perfect, and oftentimes things can light up on a PSMA PET CT scan that are not in fact malignancy, and so you have to be very, very careful when you're interpreting these PSMA PET scans. You have to make sure that they have CT correlates. You have to make sure that things that are lighting up on the PET CT scan were not present on old CTs. Things could be due to trauma or infection or things like that. So you have to be very careful interpreting these. But PSMA PET CT scan is typically obtained to kind of rule out any distant metastases. And I think NCCN has a nice sort of guideline for who should get a PSMA PET CT. I think of it as anyone that has unfavorable intermediate to high risk disease, but if they have a PSA greater than 20, if they have grade group 2 and PSA greater than 10, grade group 3 or higher, T3 to T4 disease, more than 50% of their biopsy core is positive, or a PSA that's greater than 10 and T2B or T2C disease. I realize that that's a huge list of things that's probably hard to remember right now, but these are all things that make you either unfavorable intermediate or high risk disease. And so when you have patients with that, you should get distant imaging. You should get, systemic imaging to rule out nodal or distant metastases. So that's sort of a summary of imaging. And then finally, pathology. And so you need to get a prostate biopsy, and this is typically obtained via a transrectal ultrasound. You can use a transrectal or a transperineal approach. I think transperineal approach is preferred just because of less risk of sepsis. But you typically use a transrectal ultrasound, and then the biopsy is typically obtained with a transperineal approach. And as we just said, we prefer an MRI fusion biopsy if possible, because that way we can actually, target the area that's lighting up as the abnormality. I think that was a lot of information about the workup of prostate cancer. I'm going to try to kind of go through the different pieces that we talked about in a little bit further detail now so that they make a little bit more sense. And I'm going to start by mentioning some of the scoring systems that we talked about that we can obtain when obtaining that initial H&P to kind of document patients' urinary and sexual function at baseline. So one of the things that we often document is the International Prostate Symptom Score, or the IPSS, which is used to document their urinary function. And this is kind of an example of the form that they might fill out. They basically have to rate how frequently they have experienced certain issues with urination, like incomplete emptying, frequency, intermittency, urgency, and so on. The IPSS includes both the symptom index score as well as the quality of life. So you can see at the bottom they're asked, what is your quality of life due to urinary symptoms? There's a subset of the IPSS called the AUA-SI, which is just that symptom index score alone. And then you have to add that to the quality of life score. So IPSS is really the symptom index score plus the quality of life score. And that's kind of what the IPSS is. So this is a sheet that we often in our clinic have patients fill out, not just at that initial H&P, but also at subsequent follow-ups so that we can kind of document how they're doing over time after treatment. Another common scoring system, this time for sexual health, is the Sexual Health Inventory for Men, or the SHIM score. And this is another questionnaire that kind of helps us to understand their baseline sexual function, and it kind of gives them a risk stratification, basically, of how severe their erectile dysfunction is. And I'm sure there are other scoring systems out there too, both for urinary as well as sexual functions, but these are just the two most common ones that I have seen used. It's helpful to have something like this in clinic, just so that you can kind of understand how these patients are doing. In terms of labs, we mentioned elevated PSA is something that clues you into the fact that this patient might have prostate cancer, and that prompts next steps. But I do want to take a second to kind of go over important PSA metrics that we think about. Right, so we talked about how a PSA value of greater than 2.5 to 4 nanograms per milliliter indicates that the patient might have a higher risk of cancer. I think it's important to understand that the normal PSA value really depends on the patient's age as well as their ethnicity. So you can see in the graphic on the left-hand side of this page that normal PSA kind of varies depending on ethnicity, and it also slowly rises with age. And there are also things that can falsely elevate your PSA. So manipulation, or having a previous biopsy, having BPH, having prostatitis, having urinary retention, any sort of trauma or recent ejaculation. So these are all things that can lead to false positives for PSA. And so one isolated value can often be very difficult to interpret. We also mentioned earlier that when patients are on finasteride, we have to kind of double the PSA that we see, because we know that finasteride decreases that PSA too. So if you're having trouble interpreting an isolated value, you can use some alternate metrics as well. So one of those is the PSA density. So the serum PSA divided by the volume of the prostate gland. And a value of greater than 0.15 is a higher risk of prostate cancer. You can also think about PSA velocity. So if one value is difficult to interpret, well, don't just get one value, kind of monitor it over time. And so a rapid PSA velocity is defined as greater than 0.75 nanograms per milliliter per year. So if your PSA jumps from 3 to 4 in just a year, that kind of clues you into that, okay, this person's PSA is rising kind of rapidly. If the PSA doubles within a year, that's definitely a higher risk of prostate cancer. And then the final metric I wanted to mention is the PSA ratio, which is your free PSA divided by your total PSA. And a PSA ratio of less than 25% also indicates a higher risk of prostate cancer. So these are things that you don't necessarily need to memorize, but just keep in mind that an isolated PSA value is obviously difficult to interpret. So pay attention to how fast that PSA is rising. What is the velocity? What is the doubling time? And then keep in mind that we can also calculate metrics like PSA density or PSA ratio. Now, if that PSA is elevated and continuing to rise, then the ultimate way of confirming that a patient has prostate cancer is really to obtain a biopsy, right? But as we just talked about in our workup section, the NCCN strongly recommends obtaining an MRI of the prostate before we get a biopsy, so that when we do go for the biopsy, we can do an MRI fusion biopsy and kind of specifically target the area that we're concerned about on MRI if it does show something. So when we obtain an MRI, we definitely want to get a multiparametric MRI. Now, the best MRI sequence for visualizing prostate cancer is going to be our T2 weighted image. So just like gynecologic cancers, the T2 weighted image for prostate cancer is really the best for visualizing the prostate volume as well as the zonal anatomy. And when we look at the T2 weighted image, something that's focal and circumscribed and moderately hypo-intense, so kind of darker appearing on MRI, is what's usually suspicious for cancer. Diffusion weighted imaging can also be helpful, and what you'll see is a DWI or an ADC map, which stands for apparent diffusion coefficient. And basically, the advantage of diffusion weighted imaging is that we can see areas of restricted diffusion. And that's important because cancer cells are areas of high cellularity. So typically cancers are going to be associated with restricted diffusion. And focal findings with restricted diffusion on high B-value and ADC imaging are going to be suspicious for cancer. So you look for areas of restricted diffusion. And then dynamic contrast enhancement can also help. So if the lesion is contrast enhancing, but often it can be difficult to distinguish that from the normal peripheral zone. The dynamic contrast enhancement is often more useful in the post-prostatectomy setting, where an enhancing focus can suggest recurrent cancer. So multiparametric MRI is kind of the standard that we should be obtaining. We always want to look at the T2, and then we want to look at some other sequence. And oftentimes that DWI or ADC map is going to be most helpful to help us identify areas of restricted diffusion. Here's a picture just to give an example of what multiparametric imaging for the prostate can look like, a multiparametric MRI. And in this imaging, what we see is a suspicious finding at the posterior rim of the right prostate lobe. So you can see that the abnormality is in the peripheral zone of the prostate, and that's where we most commonly find our prostate cancers. I think it's best visualized on the T2 weighted sequence. It appears as an area of low signal, so you can see that darkness or that hypointensity that the arrow is pointing to on the T2 weighted image. On the dynamic contrast enhanced imaging, it does appear brighter. But again, it can be kind of hard to differentiate that, I think, from the rest of the peripheral zone. If we look at the DWI with the high B value of 2000, you can see that there's restricted diffusion, and again, the arrow is pointing to that. And then there's an ADC map on the right-hand side, and on the ADC map, the lesion actually appears dark. But basically, both of those are showing us that there's high cellularity there from the presence of the cancer, and so it's restricting diffusion. And so that's just an example of multiparametric MRI and what it might look like. I do think that prostate MRIs are very, very challenging to interpret, so it does take some practice to, keep looking at them, and this is something I need to work on myself. So once we have an MRI showing us an area of abnormality that's concerning, we can then pursue a prostate biopsy. Now, standardly, what they would do is just sample the prostate and sample 10 to 12 different areas, sort of evenly distributed throughout the prostate. And on the right-hand side, you see an image showing the prostate divided into a grid. So various areas within the base, midgland, and apex. And they kind of just divided into different squares, and they would then sample an area from each of those squares. And having at least 10 to 12 cores evenly sampled was kind of the standard. As we just talked about, though, newer techniques allow us to fuse the MRI to the transrectal ultrasound and actually pursue a targeted biopsy. So if there's a specific area that we're concerned about, by fusing the ultrasound with that previously obtained MRI on the ultrasound, then we can kind of chase the area that we're really concerned about. And so typically what you might see in the modern area then is an MRI-guided fusion biopsy, and then you might also see the standard 10 to 12 cores that are obtained. Once we obtain the biopsy, what we're looking for is the histology, right? What do we see under the microscope? Most of the time, prostate cancers are going to be adenocarcinomas, right? The prostate is a gland. Adenocarcinomas are kind of like a glandular tissue. And so prostate cancers are going to be adenocarcinomas. For prostate adenocarcinoma, the pathologist will assign a Gleason score to the tissue that they're looking at for each of the various cores. So the way that they do this, they look at the cells under a microscope and they rate the cells on a scale of 1 to 5, with 1 being the best differentiated and 5 being the most poorly differentiated. And that is a Gleason pattern. The type of cell that they see the most of, so whatever looks most common on that histology, will be assigned a Gleason pattern. And then whatever they see next, so whatever type of pattern is the next most common, will be the second number that they assign. So an example of this is that most commonly they might see Gleason pattern of 3. And then the next most common pattern that they might see is a Gleason pattern of 4. So they will assign that tissue a Gleason score of 3 plus 4. And so the total Gleason score then becomes 7. And the different Gleason scores are then assigned into different grade groups, and those grade groups play into how we risk stratify patients into low risk, intermediate risk, or high risk. So what I've told you is kind of a very simplistic way of thinking about it. I think, an actual pathologist would probably tell you in more detail how they truly assign a Gleason score, but it's basically assigned based on what type of Gleason pattern they're seeing. And the first number is typically what's most commonly present. The second number is what's second most commonly present. And then the first Gleason pattern that they see plus the second Gleason pattern that they see is your ultimate Gleason score. And so a Gleason score of 3 plus 3 equals 6 or less is considered grade group 1 and typically falls into a low risk group. A Gleason score of 3 plus 4 is 7 or 4 plus 3 plus is 7 are both intermediate, but there's sort of a difference. So 3 plus 4 equals 7 is grade group 2 disease, and that's generally considered a favorable intermediate risk factor. If patients have a Gleason score of 4 plus 3 equals 7, that is classified as grade group 3 disease, and it's considered an unfavorable intermediate risk factor. And then Gleason score of 8 is grade group 4, and a Gleason score of 9 to 10 is grade group 5. And so this is kind of a very simplistic way of thinking about the Gleason score, but keep in mind that it's kind of based on what the pathologist is looking at under the microscope for adenocarcinoma. They're assigning Gleason patterns based on what they see most commonly and what they see second most commonly. Together, those two numbers are added together to give us a Gleason score, but the order matters. So 3 plus 4 is better than 4 plus 3 equals 7. That's probably the most important distinction to make for now. And then based on the Gleason score, we put patients into grade groups, and those grade groups kind of correspond to our risk stratification. So that sort of in a nutshell is how we think about the pathology for prostate cancer, and it's really important for us to understand what that Gleason score represents. And so going back to this image of how a prostate biopsy is obtained for a second. So say that the pathologist obtains 12 different cores, okay? And what you want to pay attention to is how many of those cores were positive for cancer, because that can impact our risk stratification. And, each core that's positive, so say they had 12 cores and 4 of those were positive for cancer, and each core could have a different Gleason score. So one core could be 3 plus 3 equals 6, another core could be 3 plus 4 equals 7, another core could be 4 plus 3 equals 7, and another core could be 4 plus 4 equals 8. Whichever is the highest, that's sort of what you want to think of as your ultimate Gleason score, because you want to treat the patient based on whichever core shows the highest Gleason score. So I just wanted to take a moment to kind of make that point, because I do think that just like breast cancer pathology reports, I think prostate cancer pathology reports can kind of be confusing to understand. So when you're looking at these reports, you want to look at, first of all, did they do an MRI guided fusion biopsy? And if so, what did that show? How many cores did they sample? Did they have an adequate biopsy? So did they get at least 10 to 12 different cores? Of the cores that they sampled, how many were actually positive? And then when they looked at the Gleason score, which core had the highest Gleason score or the highest grade group? Those are kind of the main questions you want to ask yourselves when you're looking at the pathology reports. So in a minute here, we're going to move on to talking about the staging and risk stratification for prostate cancer. So we'll talk about the TNM staging system. We'll talk about how the PSA and the Gleason score or grade group weigh into the risk stratification and how that sort of determines our treatment paradigms. Now, all of those things, the T stage, the PSA, and the grade group are sort of clinical features that we have been thinking about for a long time when it comes to prostate cancer. But just like in breast cancer, we are moving towards incorporating the oncotype score and taking into account genomic information to better guide our treatments, for example, who gets chemotherapy. We are also utilizing genomic risk scores in prostate cancer to kind of help guide further treatment decisions. I think we're a little further in breast cancer where these have actually already been validated as predictive tools. In prostate cancer, we have something called the Decipher Genomic Risk Score, which is a genetic biomarker score that's based on the analysis of 22 different genes in prostate tumors. It has been validated as a prognostic tool. So it tells us that when we obtain the Decipher Genomic Risk Score, we can kind of guess. It kind of helps us to prognosticate how, what our patient's expected distant metastasis rate is. And there are currently some ongoing studies, and at least at my institution, we are actively enrolling patients on certain NRG protocols, which are randomized controlled trials that are trying to help establish the predictive utility of these tools. So as a prognostic tool, it helps us to kind of prognosticate these patients, or how well are they going to do? What is their risk of distant metastasis? But then the ongoing trials are helping us to establish that predictive utility. So can we actually make treatment decisions based on the Decipher Genomic Risk Score? So right now, this is very much investigational. These ongoing protocols are basically taking patients with certain risk prostate cancers, and then based on that Decipher Genomic Risk Score, they are stratifying them into different arms of the clinical trial, and then they're randomizing those patients to either a more de-escalated if they have a lower risk score, or a more escalated if they have a higher risk score, kind of version of the standard treatment paradigms. So these are ongoing. They're trying to help us decide if we can use the Decipher Genomic Risk Score to either escalate or de-escalate our use of androgen deprivation therapy. But right now, it's not standard to obtain a Decipher Genomic Risk Score for everybody. I think it will be down the line, but we're not there just yet. Another kind of modern tool to be aware of is something called Artera AI, which is a multimodal AI-based tool that uses all of the patient's clinical data. So things we're going to talk about in staging and risk stratification, like their age, their T stage, their Gleason score, PSA. It also uses digitized histopathology to prognosticate the benefit of ADT. So these are some more modern tools to be aware of. I don't think we are yet uniformly, using them to guide our treatment decisions. Right now, at least the Decipher score is actively being studied in several NRG protocols. And so it'll be interesting to kind of follow the results of these studies, and we'll definitely talk about these studies in further detail in our talks on evidence. But I just wanted to mention these so that you're kind of aware that they exist. Okay, so heading towards the end of this lecture then, hopefully the last third portion of the lecture with a discussion on the staging and risk stratification. So we're going to talk about the TNM staging of prostate cancer, and we're also going to talk about risk stratification. So prostate cancer can, obviously be metastatic, where it has spread to distant organs, or it can involve regional lymph nodes. And both of those are considered stage 4 in our group staging for prostate cancer. So metastatic is stage 4B, and having regional lymph nodes is considered stage 4A. Everything else, so stages 1 to 3 in our group staging, are considered localized prostate cancer. However, localized prostate cancer occurs on a spectrum ranging from low risk to high risk. And we have multiple different risk groupings. So there's very low, low, favorable intermediate, unfavorable intermediate, high, and very high. So we're going to spend some time now talking about how we risk stratify localized prostate cancer. And then in our next talk, we will kind of understand how our treatment paradigms vary based on those risk stratifications. So if you want to think about it very, very simply in the most basic way possible, which is how I like to think about everything, there's really only 3 factors that are important for our risk stratification for prostate cancer patients for localized disease. So that is the T stage, the PSA, and the grade group, or that Gleason score. Those are really the 3 factors that are of utmost importance when you're thinking about how to risk stratify patients. You do want to pay attention to how many cores were positive in their biopsy as well. But T stage, PSA, and Gleason score, I would just drive home those 3 factors are the most important when it comes to staging and risk stratification for localized prostate cancers. So let's start with the clinical T stage. And remember, the AJCC version 8 states that staging should just be based on findings at the time of digital rectal exam. The NCCN is a little more lenient, and it does allow incorporation of MRI data. I think some of those NRG trials that I mentioned earlier too, like NRG GU009, their protocols do allow patients to be called high risk if they have findings of extraprostatic extension or seminal vesicle invasion on MRI. And I think that most physicians, if they do have obvious findings of something on an MRI, they will use that to upstage those patients. So keep in mind that by textbook AJCC version 8, staging is based on DRE, but a lot of physicians are now incorporating MRI-based data as well. And if it's kind of on the border, if it seems hazy or if it's suspicious, they'll go off the DRE. But if there's a very obvious finding on MRI, then they will not ignore it and they will incorporate that into their staging. So with that sort of preface, let's talk about the clinical T stage. And this is very important to memorize. So T1 tumors are not palpable and they are confined to the prostate. So this is something that you cannot feel. And most of the time, we're going to have a PSA that's elevated and patients are going to come in and we're going to do a digital rectal exam and the tumor won't be palpable and they'll be considered T1C. T1A and T1B are things that are incidentally detected if they have pathology for some other reason, such as a TURP, which is a transurethral resection of the prostate. That's a procedure that people might get if they have like really obstructive symptoms from BPH. They'll have some prostatic tissue resected, and incidentally, if they find prostate cancer in that, then it's a T1A or a T1B, depending on how much of the specimen is involved. But otherwise, if it's confined to the prostate and not palpable, Most often, it's going to be T1C. T2 disease is palpable disease that is confined to the prostate. So T2A involves only one side, so either the left or the right side, and it involves only half of that side. So really only a quarter of the prostate is involved. So if you feel something on the left side, if you feel a firmness on the left side of the prostate, and it's involving less than half of the left side, that would be a T2A. If it's involving more than one half of one side, so let's say now it's involving like 70% of the left side, that becomes T2B. But it can't be involving both sides. As soon as it's involving both the left and the right side on your exam, then it's a T2C. So T2 disease is palpable and it's confined to the prostate, and A, B, and C just depending on how much is involved. T3 is when it is extending to either extraprostatic extension or into the seminal vesicles. So T3A is extraprostatic extension, and that's it's breaking out through the capsule. It's not growing into any other organs, but it is kind of breaking out of the capsule of the prostate. So that's T3A. And I remember T3A is extraprostatic extension because A is a vowel and extraprostatic also starts with a vowel. T3B is when it is invading the seminal vesicles. So I remember that because B is a consonant and seminal vesicle also starts with a consonant. So the vowels is T3A and extraprostatic extension, and the consonants are T3B and tumor invades the seminal vesicles. So that is T3, when it's starting to invade into something close to the prostate. T4 is when it is invading beyond the things that we just said in T3. So if it's T4, it might be invading into the rectum, the bladder, the pelvic wall, or the sphincter muscles. Most tumors, when they're T4, they're kind of locally invading into the other things besides that organ. And so same thing for the prostate. It's invading beyond T3. Pathologic T-stage is extremely similar to clinical T-stage. The only difference is that there is no T1 in pathologic T-staging. It's just T2. So if it's confined to the prostate, it's T2. If there's extraprostatic extension, it's T3A. If it's invading the seminal vesicles, it's T3B. And then if it's invading into other organs like the rectum, bladder, pelvic wall, sphincter muscles, it's T4. So they're identical, but just in the pathologic staging, there's no T1. So how does T-stage correspond to the risk group? I've tried to sort of outline that in this table here. So if it's T1C, it's very low risk. So that means if it's not palpable, it's very low risk. If it's T2A, so less than one half of one side is palpably involved, it's low risk. If it's T2B or T2C, that makes you intermediate risk. If it's T3A, it's high risk. And if it's T3B or T4, that makes you very high risk. So if the seminal vesicles are involved or beyond, then it's very high risk. But if there's only extraprostatic extension, that's just high risk. And then remember that for risk group, we also put together the information of the T-stage along with the information from PSA and the Gleason score. So very briefly, how does PSA correspond to risk group? So if the PSA is less than 10, that's low risk. If the PSA is 10 to 20, that makes you intermediate risk. And if the PSA is greater than 20, then that puts you into the high risk category. So PSA is much simpler to remember, I think. So less than 10 is low, 10 to 20 is intermediate, and greater than 20 is high risk. And then finally, we have our Gleason score and how that plays into the risk group. So grade group 1, which is a Gleason score of 6 or lower, is low risk. So either very low or low risk. Grade group 2 is when your Gleason score is 3 plus 4 equals 7. That is a favorable intermediate risk factor. Grade group 3 is 4 plus 3 equals 7, and that is an unfavorable intermediate risk factor. So 3 plus 4 is 7 is favorable, 4 plus 3 is 7 is unfavorable, but 7 is intermediate. Grade group 4 or 5 correspond to 4 plus 4 equals 8 or 4 plus 5 equals 9. And those make you high risk. Now, grade group 5 can also be if you have 5 plus 4 equals 9 or 10. And that makes you very high risk. But basically, if your predominant Gleason pattern is 5, then you're automatically very high risk. But if you have a Gleason score of 8 or 9, then you're just high risk. But as soon as 5 is your predominant pattern, then it's very high risk. So the Gleason score, I think, is a little bit more complicated just because there's more subdivisions, but 6 or less is low risk. 3 plus 4 is 7 is favorable intermediate. 4 plus 3 is 7 is unfavorable intermediate. 8 or 4 plus 5 is 9 is high risk. And then 5 is your predominant pattern. So either 5 plus 4 is 9 or 5 plus 5 is 10, automatically very high risk. Now, everything we just mentioned are sort of the risk factors for different risk groups, right? So particular T stages can be risk factors for intermediate or high risk. Particular Gleason scores can be risk factors, and then particular PSAs can be risk factors too. Basically, if you have any of the highest risk features, that puts you in the highest possible group you can be in. So if your highest risk feature is a 3 plus 4 equals 7, but then everything else is low risk, like your PSA is less than 10 and you're a stage T1C, then based on that Gleason score 3 plus 4 equals 7, you would be favorable intermediate risk. And so that's kind of how you think about it. But let's sort of put it all together and hopefully it starts to make some sense. So starting with the very low risk. So if you have T1C disease, grade group 1, so your Gleason score is 6 or less, and your PSA is less than 10, and you have less than 3 cores positive with less than 50% of disease per core, then you can be very low risk. If you have T2A disease, so part of less than 50% of one side, so less than 25%, let's say, is palpable, and you have grade group 1 disease, and your PSA is less than 10, then you can be low risk. To be favorable intermediate risk, you need just any one of the intermediate risk factors that we mentioned. So T2B to T2C is an intermediate risk factor. So if more than half of one side is palpable, that makes you an intermediate risk factor. If you have grade group 2 disease, so remember grade group 2 is 3 plus 4 equals 7 for that Gleason score, that's a favorable intermediate risk factor. And then if your PSA is between 10 to 20, if you have any one of those risk factors and less than 50% of your biopsy cores are positive, then you're considered favorable intermediate risk. But if you have more than one of any of those intermediate risk factors, or you have more than 50% of biopsy cores positive, or you have grade group 3 disease, so Gleason 4 plus 3 equals 7, then that automatically makes you unfavorable intermediate risk. So favorable, you can be 3 plus 4 is 7, you can be T2B or C, you can have PSA greater than 10, less than 20, but you can only have one of those. The minute you have more than one of those, or greater than 50% of your cores are positive, then that automatically makes you unfavorable. And if you have Gleason 4 plus 3 equals 7, that also automatically makes you unfavorable. Now, the high risk features, so if you have T3A, so extra prostatic extension, that makes you high risk. If you have Gleason 4 plus 4 equals 8 or 4 plus 5 equals 9, then that makes you high risk. Or if your PSA is greater than 20. And then finally, things that make you high risk, if you have seminal vesicle invasion or beyond, so T3B to T4, if your primary Gleason pattern is 5, so 5 plus 4 or 5 plus 5, or if you have more than 4 cores in your biopsy with grade group 4 or 5, that makes you very high risk disease. So I think, this table, if you're going to memorize anything, is worth memorizing because you need to be able to risk stratify the patients. And that, as you will see in our next lecture, really defines our treatment paradigms. So how we risk group these patients, it impacts how we stage them into our group staging. It impacts what we think their prognosis is going to be, and it strongly impacts how we think about treating them. I think the distinction between favorable and unfavorable intermediate risk, and then the distinction between high risk and very high risk, is very, very important to sort of memorize. And so hopefully kind of systematically going into the main things that play into risk grouping, the T stage, the PSA, and then the Gleason score, hopefully that has helped us to kind of understand how we risk group these patients. But everything that we do for prostate cancer kind of hinges on what the patient's risk grouping is. So really take the time to kind of memorize this, and you'll see how it impacts our group staging here in a second. And then in the next talk, you'll see how it impacts our treatments. So here are our group staging, that kind of putting it all together, coming from the NCCN guidelines, and this is AJCC version 8. So we already talked in great detail about T staging, and that's honestly probably the hardest thing to memorize is the T staging. The N stage is easy. So N0 is no nodal mets, N1 is any regional nodal mets. And regional nodes are considered internal and external iliac, obturator, and presacral nodes. For the M stage, M0 is no metastases, M1A is non-regional lymph node metastases, so like para-aortic nodes, for example. M1B is bone mets, so B stands for bone, and M1C is anything else. So then we get into the group staging, and if you do RADONC questions or something like that, there might be actually questions where you actually have to say if the patient is 2B or 2C or 3A based on various information that they give you. I think that's a lot. I think for practical purposes, the best things to realize is that group staging for prostate cancer is affected not only by TNM staging, but also by the PSA, as well as the grade group. So stage 4, I think, is the easiest to memorize. So stage 4B is if you have any metastases. So if you have any M1, that's automatically stage 4B. The other thing that's unique for prostate cancer compared to a lot of other cancer sites is that the presence of any regional lymph nodes automatically makes it stage 4A for prostate cancer. And that's pretty unique because for most other disease sites, having regional lymph nodes is typically a stage 3 sort of thing. But for prostate cancer, the presence of regional lymph nodes automatically makes you stage 4A. So that is certainly worth learning. And then very simplistically, I think it's helpful to remember the things that make you stage 3. So having T3 to T4 disease, having grade group 5 disease, or having a PSA of 20 or higher, these are all things that make you stage 3. And then everything else is stage 1 to 2. And then, also I think it's helpful to realize that for stage 1, your PSA has to be less than 10. As soon as your PSA goes above 10, or you have T2B disease or higher, then you're stage 2. So it's hard to kind of go through and memorize every single one of these. I think it's more important to memorize how the risk groupings are obtained, and then just kind of remember these simple things to help you kind of get a sense of what stage they're in. And then in practice, if you ever need to, this is always something you can look up. But learning that risk stratification for very low, favorable, intermediate versus unfavorable, intermediate, and then high and very high, I think that is of most importance and most value clinically when we're managing prostate cancer. So I want to stop there for now. I realized that was a ton of information about the workup and staging, and then the risk stratification for prostate cancer. I think the way that we risk stratify prostate cancer is kind of complicated. It's different than other disease sites where we're not just using the TNM staging, but we're also using their Gleason score. We're also using their PSA score. So, hopefully especially if you're learning this disease site for the first time, hopefully you can spend some time with the risk stratification and understand how we kind of think about that. I think that'll help. And then in the next talk, we will do an overview of our treatment options for prostate cancer based on the risk group. And then in future talks, we'll actually dive into the data and talk about the important studies that kind of guide that management. So hopefully this was a good overview of prostate cancer, and hopefully some of the important features of workup, such as the imaging and the biopsy. Hopefully you got something out of that. And then hopefully these risk stratification, that whole process makes sense. And then I look forward to seeing you in our second part of this talk where we'll get into the treatment options. Thank you for your time.